Hello, good evening. My name is Sophia. I think we only have, is it Paul, who's watching at the minute? But Dee will be joining us later, and we'll see if there's anyone else who joins as well. But welcome to the session. I hope you're having a good evening. We'll wait a couple, maybe 1 or 2 more minutes to see if anyone else joins, and if not, we'll get started. Okay, we'll make a start. Welcome to this session on gastroenterology. My name is Sophia. I'm an FY1 doctor working in North Manchester at the minute. My current placement is radiology. So this will incorporate quite a few scans and radiology that I think would be useful, not only for exams, but also for FY. And my previous block was in surgery. And so I know a little bit of the gastro and the surgical side of it. So let's get started. So the main learning outcomes today are just to know what the main presenting complaints in gastro are and how we can use our diagnostic skills to figure out what the diagnosis is. And we'll talk about interventions and management. We use the MLA as the basis for what topics to select. The MLA does tend to highlight a couple topics, so we'll go over those in this session, but just to make you aware, there are quite a few in here that we would recommend you read, such as necrotizing enterocolitis that we won't cover today, but may very well come up in the exam. So we'll do a question. If you've been to any sessions before, we do a question, we wait about a minute, and then we'll go through the answers and explanations. So the first question, your minute starts now. 60-year-old woman presents to the ED with worsening colicky, abdominal pain, fatigue, past 2 years. She's not jaundiced, blood show elevated ALP, GGT, and bilirubin, and on examination, there's marked GARDing. Since arriving in the ED, she's vomiting, and an abdo X-ray shows gas in the biliary tree. What's the most likely diagnosis? And Paul, since you're here, if you're ready, you can just say you're ready in the chat and we can move on. Okay, so that's about a minute. So this question is focusing on this woman who's had this abdo pain, and you have all of these diagnoses that could be the potential diagnosis. The correct answer here is gallstone ileus, and I'll explain why. So from the history, it sounds like she has a picture of cholecystitis, and it seems like it's recurrent cholecystitis. So immediately off the bat, we're thinking it could be A, B, or C. It could be a cholangiocarcinoma, recurrent cholecystitis is a risk factor for cholangiocarcinomas developing. It could be an acute episode of cholecystitis itself, or it could be a gallstone ileus, especially with the gastroenterology, and I'll come on to that in a minute. So then we have a look at the vomiting and the pneumobilia. So gas in the biliary tree, or the fancy name pneumobilia, is pretty much pathognomonic for a gallstone ileus. And what that means is that a gallstone from the gallbladder has found its way into the gastrointestinal tract, and it's called a blockage somewhere in the small intestine. And what that's done is, because there's a small bowel obstruction, the patient will be feeling like they're vomiting, they'll be feeling really unwell, and that counts as an acute abdomen. So why is it not cholangiocarcinoma in this case? So she has had this for the past 2 years, and she's also feeling fatigued, which could point towards cholangiocarcinoma. As you know, fever, weight loss, and fatigue can all point towards tumor. And to be fair as well, cholangiocarcinomas can also lead to pneumobilia if the tumor erodes from the gallbladder into the duodenum. So, but the key thing here is that she does not appear jaundiced. Cholangiocarcinoma is normally a long-term process that does present with jaundice and a long-term buildup of bilirubin. And you would expect a sort of more chronic. She could have a chronic background of this, but the acute problem that we're dealing with here is the gallstone ileus, especially with the vomiting and the pathognomonic finding of the pneumobilia. So that's why this question is highlighting what's the most likely diagnosis. Acute cholangitis tends to present with the Charcot's triad. I always look for abdominal pain, jaundice, and fever, and if the question doesn't mention one or all of those, then I don't think about cholangitis. And then biliary colic. So biliary colic is when the pain just comes and goes, but it wouldn't present so acutely like this. So well done if you got that right. That's just a quick explanation. And as I said, gallstone ileus, gallstones in the bowel, and how we'd investigate it. So in like, if you write notes and things, that's how I revised for med school. I just wrote like bloods, get an abdo x-ray, and then maybe a CT tap. But in practice, you'd actually do a whole host of bloods, and that's really useful to know when you're doing OSCE exams. Say, for example, you think a patient has this in an OSCE, you would say, I would want to perform further tests, such as bloods, FBCs using these LFTs, CRP. If it's an acute abdomen, you could always add in an amylase. I would want to order some blood cultures in case they are septic. And then other bedside tests alongside bloods. So you could do an ABG, a VBG, an ECG. If the patient is a woman and they have acute abdominal pain, almost always you do a pregnancy test. And another bedside test would be BMs. And then, so bloods, bedside tests, and then imaging. I'd think about chest x-rays in case there's perforation, ultrasound abdo if I'm suspecting a cholecystitis, I put chest x-ray twice, CT abdo, and then ERCP or MRCP. And then for management of gallstone ileus, I don't know if you've heard of drip and drain before. Drip and drain is just a really quick way of remembering what to do if someone has a small bowel obstruction. So you want to drip them, so put in a drip, IV fluids, and drain them. So put an NG tube and try to relieve all the fluids that's building up behind the obstruction. Because these patients, they might be vomiting quite a lot and they'll be losing quite a lot of electrolytes. And biliary drainage eventually. Oh, hi, Dee.
Hi.
Hi,
Hi, everybody. Sorry, there was a bit of a delay. Me trying to get in. I was still at work, but yeah, I'm here now.
That's okay. So we've just done the first question. And yeah, so yeah, this is Dr. D. She'll do the second half. So just a few slides on actual gallstone annulus in radiological findings. So if you do an abdominal X-ray, it can look quite intimidating at the start. But what you're looking for is sort of air under the diaphragm. In a chest X-ray, you're looking for air under the diaphragm. And an abdominal X-ray, you're looking for any sorts of bits of bowel that look expanded more than usual. You're looking to see whether the walls of the bowel have air around them, whether you can see like a sort of double walled of intestines. And what I've circled here on the left side, you can actually see gas inside the biliary tree, and that's what's called pneumobilia. It's quite subtle if you're not looking for it. And there's a radiological sign called Wriggler's triad, which shows the gas in the biliary tree at the top. On the right image, you can actually see the gallstones inside the bowel, and then you can also see that the bowel is slightly more dilated than it would usually be. That's called Wriggler's triad. And just as a quick refresher, when you're presented with any sort of acute abdomen, I like to think of it in terms of anatomical location, but that can get quite difficult if you're presented with general abdominal pain. So then I tend to think about vitamin C def or Vindicate withdrawal mnemonics to help you differentiate different types of differentials. So V would stand for like vascular, I infection, T trauma, etc., etc. So it will help standardize your answers in an OSCE scenario if the examiner is asking you for your differentials. So for example, here if we had right upper quadrant abdominal pain, you'd think about all of the pathologies in the gallbladder and the liver, cholecystitis, cholangitis, etc., etc. And that would look really, really slick in an OSCE situation, and also when you're just doing doctoring. So next slide. Oh, so I've just got a summary slide as well. I promise not every question is going to be as extensive, but this is really important to just differentiate the different diagnoses of gallbladder disease. And it can be quite overwhelming when you actually see it next to each other. But what I've done is at the bottom, I've put just clues that would point towards each diagnosis. So if the question does mention like a high calcium or lipase, just immediately think it could be pancreatitis. So those are the differentiating factors. Again, you'll get the slides at the end. So question 2. A 65-year-old man presents to the acute medical unit with abdominal pain and bloody diarrhea after coming back from a long walk in the Pentlands. On examination, he is apyrexial and tender in the left iliac fossa. Bowel signs are present and normal, and his new score is 0. Past medical history of asthma, hypertension, NAFLD, and gout. Given the likely diagnosis, what is the most appropriate diagnostic investigation? Yeah, about a minute. Okay. So the correct answer here is a CT abdo. And to be honest, pretty much like 90% of patients who come in to the ED, I'd say have a CT abdo with abdominal pain. So let's go through the answers. The key clues here, they've got abdominal pain, bloody diarrhea. So immediately you're thinking about your differentials. You're thinking about, if we go through vitamin C deficiency mnemonic that we talked about before. So vascular, it could be ischemic, it could be like ischemic colitis or mesenteric ischemia. It could be some type of infection that you might want to do a stool culture for. It could be trauma. It doesn't mention any trauma in here. So you could just go through those differentials. You're also thinking about like angiodysplasias or diverticular disease, IBDs, even hemorrhoids, which is quite common in GP land. So you've got those differentials in your head, and you know that he's come back from a long walk in the Pentlands. So what that could suggest is maybe he's a bit dehydrated. Maybe this long walk has precipitated this episode, which points to a clue of what the diagnosis is. Apyrexial, and it's in the left iliac fossa, so it's unlikely to be some kind of infection unless he does have diabetes, but he doesn't at this point. So he's apyrexial, and his news is 0. So it's not like, oh, he's acutely, well, he might still be acutely unwell. The news score doesn't always represent the patient's, whether the patient is stable or unstable, but his news is 0. And he does have a background of these cardiovascular risk factors, such as NAFLD and hypertension. So in this situation, we're thinking, okay, CT abdo, it's non-invasive, his news is still 0, and it can detect a lot of things, such as it can detect whether it's diverticulosis, it can detect ischemia. If we were really worried about ischemia, we could do CT angio, which is where they put dye into the arteries, and they take a scan of the abdomen while the dye is inside the arteries, and you can see it leak out, and then you can see it clear after a couple more seconds, and they scan the abdomen again. So that's a really good non-invasive way of investigating whether there's a bleed, any obstruction, any other abnormalities. Colonoscopy, it's a bit more invasive, and you would consider a colonoscopy, especially if they are hemodynamically unstable. They might need an immediate intervention, in which case an emergency colonoscopy and emergency OGD may be indicated. But it mainly detects sort of abnormalities in the, or pathologies in the left colon. It can go all the way up as well, but in this setting, you would want to see whether there's anything in the right transverse or left colon as well, to see if there's any source of that bloody diarrhea, especially since they have the pain in the in that left side of the iliac fossa, but it could come from anywhere. The abdominal x-ray. So I know we did an abdominal x-ray for the previous one, but we don't tend to use it as much in practice, mainly because we know that it's not as specific as a CT abdo. So if you're in a real pickle, you can use an abdominal x-ray, but in this case, the CT abdo would be most appropriate, especially given the most likely diagnosis, which I might have given it away already, but we're thinking it's something ischemic, especially with the long walk and the cardiovascular risk factors. An abdominal x-ray would not pick that up. Stool culture, again, it could rule out an infection, but it would not give us the answers to the most likely diagnosis. And a venous blood gas, again, would show maybe a raised lactate, and it would be part of your immediate bedside tests, but it would not be the most appropriate diagnostic investigation. have a quick explanation. And so as a med student, I also kind of struggle to differentiate between mesenteric ischemia and ischemic colitis. So I've just put in a table to help you guys, just for revision. So mesenteric ischemia, it tends to be more sort of acute, and due to an embolus blocking the arteries and blocking the blood supply to the bowel. And patients tend to have a background of atrial fibrillation because we know that atrial fibrillation predisposes to clots. So it does tend to present more suddenly with more severe onset, and affects the small bowel. Much of the investigations are very similar between mesenteric ischemia and ischemic colitis. Except with mesenteric ischemia, you're thinking it's more urgent. You have to get rid of that emboli or embolus really quickly. So you're going to give the antibiotics and try to go for urgent surgery. Ischemic colitis tends to be a bit more insidious, and is more likely to present with bloody diarrhea because ischemic colitis, as it's a bit more chronic, it has more time to get to a later stage where the patient would get bloody diarrhea. And I think classically, especially if you do PASMED or QuestMed, it says the patient gets pain after eating, and that's just because the intestines are increasing their workload by having to digest all the food. So it's a little bit like angina, but in the intestines. And just some radiography for you guys. So pneumatosis intestinalis is just where you see that, where the arrow pointing is on the left. You've just got that swelling and edema around the bowel, and that's showing that's a bit inflamed. And you've got a bit of fat stranding there, and you can see that it's just not happy compared to the regular bowel. The wall is also thickened. Again, it's inflamed. Seeing black inside the colon is normal. So it's just the wall around it that looks unhappy. And then on the right side, you can see something called thumb printing, and it looks like there are little thumbs printing in towards the bowel wall. And sometimes it can look a little bit like diverticulosis. You just kind of have to get an eye for which is pointing in and which bits are pointing out. The one on the left, again, that's a CT angio. So all the white bits have dye inside the arteries, and you can see there's a little sort of black thrombus on the inferior aspect of that blood vessel. So you can very clearly see whether there's a narrowing in the vessels on a CT angio, and that's why it's so useful. And on the right, you've got a 3D reconstruction of a patient who's had an EVAR, and just on the SMA on the anterior aspect of that aorta, you can see it's again narrowed. So again, if you're in ED, in emergency department, then you might see these images, and you'll be able to say, oh, it's ischemic bowel, even before it gets reported. So the next question. 11 months old baby boy brought to A&E. His mother is concerned he's losing weight over the past 3 months, passes 3 stools a day, and his older brother has type 1 diabetes. On inspection, his abdo is distended and his buttocks are wasted. His abdo is soft with no hepatosplenomegaly. What is the gold standard investigation for the most likely condition? And you have about a minute.
Sophia, sorry to ask this. For the last 5 questions, is it okay for you to just flick through the slides, because I'm not going to be able to control it and bring it up if that.
Yeah, of course. Just let me know when you want to change the slides.
Thank you.
That's okay. that's about a minute. And just before I go over the answers, I can see some comments in the chat. So I'll go over them at the end if that's okay. Or at the end of this 5 sets. So for this question, what's your most likely diagnosis that you're thinking about? It's a baby boy who's losing weight, has loose stools, and has some kind of autoimmune disease, type 1 diabetes, is in the family, and is having basically faltering growth. And if you thought celiac disease, you'd be correct. Celiacs. So this question is asking for the gold standard, and technically you can do anti-EMA antibodies, you can do anti-TTG, and you can do small bowel biopsy, and that will all tell you the diagnosis, but this question is asking you for the gold standard. And the gold standard would be a small bowel biopsy, and that would be through an OGD. Again, it's not asking you for the initial investigation. The initial investigation would be to do the blood tests, but the gold standard, and gold standard means it has the highest sensitivity, which means that if you have the disease, then this is most likely to be positive, and also the highest specificity, which means if you don't have the disease, it's most likely to be negative. And small biopsy is a gold standard for celiac disease. So yeah, it's a quick explanation. You could also do an anti-gliadin test as well, would be considered a first line. So talking about celiac disease, it's T-cell mediated, and it's associated with a bunch of autoimmune diseases. So if they mention autoimmune diseases in the family, just try and think celiac. Even in just general practice, if someone just says I have diarrhea and someone has type 1 diabetes, immediately try to think about celiac, because it could get underdiagnosed. So they tend to present with abdominal pain, bit of nausea. They might have some fat in their stool because they're not able to digest the fat properly, or their bowels having an inflammatory reaction that's causing all of the food to pass through without getting digested properly. It's important to really check for their vitamin deficiencies and for anemia, because we know that these are replaceable. So in terms of investigations, again, as with an OSCE scenario, we do the bloods, the bedside test, or the stool cultures. The serology comes under bloods as well. So you do anti-TTG and your total IgA levels. And the reason why we do the total IgA levels on top of the anti-TTG is because if there is a deficiency in IgA, then it can skew with the anti-TTG results as well. So we want to know that that total IgA level is normal, and then we can have a reliable anti-TTG level as well. So when you're thinking anti-TTG, always order an IgA in your serology as well. But the OGD and jejunal or duodenal biopsy is considered the gold standard. And you'd see sort of villus atrophy and all these things, crypt hyperplasia. Very unlikely that they'll give you a slide to interpret in the exam on the MLA. And management, gluten-free diet. Another thing to note is when someone is taking a blood test, is doing a blood test for anti-TTG, they have to be having gluten in their diet already, because the anti-TTG responds to gluten. So if someone's already on a gluten-free diet, the anti-TTG won't be raised. So you have to encourage them for about 2 to 4 weeks to eat a gluten diet and then come back for that blood test to get diagnosed. And then they'll need regular blood tests, because we know that anemia is a complication. And just make sure that they could have iron tablets. If this is an OSCE scenario and they give you some blood tests which show deficiencies, you score really good marks if you can recognize that, oh, anemia is a potential complication. I'd want to give iron supplementation if required. Oh, next question. So question 4, 13-year-old girl brought to the acute walk-in clinic at GP by her mother. She reports extensive vomiting and diarrhea starting about an hour ago, not noticed any blood, and her mother states that they attended a birthday party at a friend's house where she ate sandwiches and finger food. So you've got another minute. Okay, and that's your minute up. So this question, probably the most unbelievable part about this question is that this person got a GP appointment within an hour. But so you've got a 30-year-old girl, had vomiting and diarrhea starting about an hour ago, no blood. So it's a very quick onset type of thing. And pathologies that are very, very quick onset, you're immediately thinking it's going to be some sort of infection, especially when there are other people around as well. So when you're doing an OSCE for this, make sure to ask if anyone else is having similar symptoms. So something that started about an hour ago, the main pathogen that you're thinking about here is going to be Staph aureus, because it does have one of the quickest onsets, about 1 to 6 hours onset or incubation period. So it can happen very, very quickly, and it is associated with sort of foods that don't need to be cooked. So like raw foods or sandwiches that don't generally need to be like heated up. So questions that need Bacillus cereus tend to involve foods that have been left out for a long period of time. The classic example would be rice, and the diarrhea would be sort of a lot more watery. Again, you wouldn't expect any blood in that diarrhea, but it wouldn't onset so quickly. Norovirus, the classical presentation of norovirus is like a bunch of people who are presenting at the same time and something's gone around in school. It's very, very contagious. It's actually gone around my hospital a couple of times and somehow managed to avoid it every single time. But so norovirus tends to present with like a lot of public health type of issues. Salmonella. If they're pointing you towards salmonella, it will most likely be bloody diarrhea. And Campylobacter jejuni, similar. It does tend to be bloody, but you'd also have a history of more so meats. The classic thing is like a summer barbecue, or having sort of more raw foods. But the key thing here is that it happened about an hour ago and it was not bloody. Yeah, so gastroenteritis in general. Again, we're going to go through the same motions of the investigations, your bloods, your FBC, U's and E's, electrolytes. Anyone who has sort of loss of fluid, I do electrolytes because they might need replacement. So magnesiums, your bone profiles, your phosphates. I guess in a child, it might not be as pertinent. Your bedside tests, such as the stool culture, or your stool sample, and send it for your microscopy sensitivities. And Especially in patients who are in hospital who might be taking antibiotics, you want to check for C. diff. C. diff is also something that spreads very quickly around the hospital, and it's taken very seriously because it can make patients quite unwell and very dehydrated. And yeah, you can take blood cultures if they're septic. So the main ways to treat gastroenteritis in community, it's mainly supportive. So if they need oral hydration salts, you could provide that if they're really, really dehydrated. But in hospital, we tend to do barrier nursing and sort of supportive management with IV fluids. If you're in an OSCE and someone has gastroenteritis, think about notifiable diseases as well. They really like to see that you're forward thinking. Pretty much all types of food poisoning are notifiable diseases. But even if in doubt, you can always say, I would check to see if there's a notifiable disease. And consider antibiotics. Most things are self-limiting, but make sure to safety net at the end of whatever OSCE scenario you do. So I've just done a couple of quick tables. So the first table is bloody diarrhea, and these are the sort of classic ones that you might get in the exam. And again, I put a clues column, so things that if you see it, you should recognize it immediately and think of the respective diagnosis. And the things that take the longest to incubate, surprisingly salmonella, but also like Giardia lamblia takes a long time to incubate. And it does tend, so Giardia lamblia, I've actually seen quite a few questions on that recently, so I don't know whether the UKMLA is starting to get more obsessed with like pathogens from abroad, but yeah, just keep reading about the different types of infections and how they present. Okay, question 5. A 40-year-old woman presents to the GP concerned about a persistent groin lump, and she first noticed the lump about 1 month ago and is otherwise painless. On examination, the lump is located below the inguinal ligament on the left, lateral to the pubic tubercle, and has a cough impulse. There are no signs of inflammation, and she has a BMI of 29. Which of the following is the most appropriate management plan? And your time starts now. Okay, I'm going to stop it there. So this is a case of a hernia. If you know your hernias, then you'll be sound. Sometimes it's quite easy once you get your head around it, but it can be quite hard to remember at the start. So hernias that are below the inguinal ligament and lateral to the pubic tubercle are femoral hernias. But if they're medial to the pubic tubercle, then they tend to be more inguinal hernias. And the difference between inguinal and femoral hernias is how you manage the main difference is how you manage them. Because femoral hernias, they tend to be through a hole that's a bit more narrow, and they have a higher chance of strangulation. So they need to be dealt with very urgently. Inguinal hernias, on the other hand, they can pop in and out. You can have direct hernias and indirect hernias, and they tend to be a bit more like flexy. So they can pop in and out. They're less likely to get strangulated. It's less likely to be emergency, but obviously you would still want to get it repaired. So in this scenario, this lady, she's had a persistent groin lump. It is painless for now, but she is showing signs of a femoral hernia. And we know that femoral hernias are very high risk. And so what we'd want to do here is we'd want to do an urgent referral to general surgery. And what general surgery can do then is that they can either confirm the groin lump on examination, or they might do an ultrasound as well. If she's a really, really high BMI, they might consider an MRI or CT for surgical planning, but that's up to general surgeons to decide. We shouldn't routinely do CT or MRI scans for hernias. So if this is a femoral hernia, we want to do an urgent referral to general surgery. If the case was that it was an inguinal hernia, then we can be a bit more relaxed about it. We would still do a routine surgical referral, and we would advise the weight loss as well, but we wouldn't really have that period of advising weight loss before the surgical referral, because once the hernia is present, then it's unlikely for it to self-resolve once there is already a hole in the abdomen. But you'd always want to do a surgical referral anyways. And referring to A&E is a bit extreme. If it were painful, very, very painful, it could indicate that this hernia has already been strangulated. So strangulated is different from incarcerated, in that incarcerated means that it's irreducible, so you can't push the hernia back in. Like, it's kind of stuck there, but the tissue is still all alive and it's still kind of healthy. Whereas strangulated means it's stuck and it's also sort of compressed, and so it's like a little hole, and then the hernia is sort of outside that hole, and because it's bulging out so much, all the blood vessels going through the hole are getting compressed, and then that cuts off the blood supply to that hernia, and then it starts to become necrotic, and it becomes really, really painful. So that's what a strangulated hernia would be, and that would be an urgent referral to A&E. So it's femoral hernia. So hernias are outpouchings of bowel through the abdo wall, and differentials could include lipomas, femoral artery aneurysm, I've not seen it though, and lymph nodes. Lymph nodes are very, very common. So the main ways to investigate it are the physical exam. Not many blood tests you could do. And then your imaging is the ultrasound, and general surgery, if you've already referred them, will tend to order the CT or MRIs if they want it. And you can always do an abdo x-ray and a chest x-ray if you're suspecting that there's been a perforation because that bowel has been like squished and backlogged, and then all the food and stool behind that might build up and cause the bowel to burst. So management, if it's a femoral hernia, you want an urgent repair, either laparoscopic or open, due to the high risk of strangulation. If it's inguinal, and you can't reduce it, then it's an urgent surgical referral. If you can reduce it, it would be a routine surgical referral. And if it's strangulated or any signs of intestinal obstruction, or the patient's really, really unwell with it, then send them to A&E. So just some imaging. So on the left is an ultrasound. You can see the femoral artery and the femoral vein, and you can just see this big bulge that's not really meant to be there, and that's passing, I can't remember what it's called, but there's a specific triangle that it goes through. And then on the right, you can see a very obvious sort of the bowel is coming out of the abdominal wall, and you can see it at the very bottom there. So pneumoperitoneum, gas under the diaphragm, that's basically what it looks like in very severe cases, but it won't always look like that. It might be very subtle. So that's what the image on the right is showing. And I think it's very fair for examiners to include this in an OSCE as well. So if they show you a chest x-ray and it has air under the diaphragm, think about pneumoperitoneum. And again, my tables, I love my tables. Femoral hernia tends to be in middle-aged women, and then inguinal hernias tend to be in men. I can't remember the exact reason why. I think it's because the way the pelvis is structured, women have a wider pelvis, and it just makes it more prone to having femoral hernias. And then the key thing to note between direct and indirect, the way I think of it is just, the way I remember it is if it's directly through the abdominal wall, if it pokes out the front, then it's an old man. And if it's like in the testicle, it's probably an indirect in a young boy. I think that was all of my 5 questions. Dee, do you want to do question 6?
Yeah, sure. Sorry, I'm on 2 cameras. I'm logged on in 5 places just to make sure that I'm definitely logged on. So you get 2 profiles of me. Hopefully Sophia's going to be able to just go through the slides, and I'll speak through. So just going back, it was Hasselbalch's triangle. That is the key word. So if that comes up in an exam, think of hernias. Okay, if you remember any word from that last question, sometimes it is as much about knowing the clinical stuff, obviously, but sometimes we just have to get through some exams and get it done. Right, so next question. I'll go through the question first, then we'll go through the theme of it and then explaining it. Okay. So the question is, if you've got, so every bit of this question you need to think about. So you've got a white UK resident, 64-year-old male who presents after 3 to 4 months of worsening dysphagia, so issues with swallowing, and odonophagia, meaning painful swallow, which is exacerbated by meats and bread, which, i.e., basically girthy food, right? Whilst he has no issues with red flag symptoms, he reports 2 episodes of vomiting after meals in the last months or so over the last 6 weeks. He is sent for a barium swallow, which shows esophageal shouldering near the gastroesophageal junction. He admits to occasionally enjoying cured meats, but does enjoy a hot curry most of the time. And he had a viral infection about 1 month ago. He's got a family history of autoimmune diseases in the family. So what is the most likely diagnosis? So I'll give you a few minutes to look through that.
I can time for you, Dee, don't worry.
Thank you. I've at least got a watch, at least I can time the minute. Whilst you're figuring that out, I'll highlight some of the key things. So we're looking at a white Caucasian male. You've got issues with swallowing. He's had vomitus. He's having issues with swallowing food. He's had a barium swallow investigation, which shows shouldering. There's a line in there about enjoying cured meats and hot curries. Now, this is only really relevant if you've remembered the differential diagnoses of different like dysphagia diagnoses. If you don't remember the nuance of it, just go with your gut instinct. I think the answers, they're good in that. So I think you've got a 50% chance of getting it right, even though you've got 5 options, because you can at least hopefully distinguish between whether it's cancer or not. There's only 2 types of cancers on that list. So if you can figure out, so if I've said 50% means it's not the last 3, basically. You can figure out the other ones. That bit of knowledge comes from if you revised dysphagias.
It's been a minute.
Right, okay. So we'll go to the next slide and I'll explain why it is what it is. So the answer is A. It's adenocarcinoma. And the reason being, so as I said, you've got 50% chance of getting it right. So you should have guessed that it's at least, hopefully, a cancer of some regard. Good, someone's written adenocarcinoma. Very good, well done. So it is adenocarcinoma. You've got to figure out now, if you don't know anything about where you should get shouldering or not shouldering on a barium swallow, and you can't remember that. If you can figure out the fact that this man enjoys lots of curries, and the cured meats and the bits highlighted in blue are kind of red herrings, because those things can coexist in a patient like this, and those blue things highlight to achalasia. Okay, but the fact that this man has a lot of curry means that he's probably got reflux. Okay, and if he's got reflux and he's got chronic reflux, he might have Barrett's esophagus, which means you'll get migration of the cells from the stomach lining into the esophagus itself. And if you think about it, that migration of cells is it's not going to be squamous, so you're going to have, yeah, exactly. Yeah, so Paul's got it right. So he said, distracted by the recent viral infection, but you've got to remember the viral infection. So the symptoms he's been getting predates the viral infection. Yeah, so he's coming because of 3 to 4 months of worsening. He just happens to have got a viral infection about a month ago, but he's been having, and the issues with the vomiting also predates the viral infection. Sometimes some of these questions are a bit more, it's like a verbal reasoning exercise, but we try and reflect the question styles that you'll get. So that's why that bit of information is there. But as I was saying, if you get the migration of the cells from the stomach lining, you're going to get adenocarcinoma as opposed to squamous, because squamous is more sort of higher up. Okay. So next slide, please. Yeah, so that's what that question is talking about. Let me just close the chat because I'm getting a bit distracted there. Right, so a bit about esophageal cancer. So it features anorexia, vomiting, painful swallow, but dysphagia is the most common symptom, and that's quite worrying because you can get that with so many different conditions. So it's really important that you figure out what the dysphagia is with. Is it with solids? Is it with liquids? And if you're worrying about cancer, it's really important to ask. So if they're struggling with liquids, you need to ask them in their history, have they had issues with solids first, and has it now become worse at that, to the point that they're even struggling with liquids? That is telling you a bit about the progression of disease. That's really quite fast. As Paul mentioned, one of the other people who've attended today, achalasia is an important differential. It's induced by viral infections. You get triggers basically for it. It's important to rule out foreign objects if they've choked on anything, especially with children. Esophageal stricture, it can happen with dysmotility syndromes, but also with progression of cancers. You can get autoimmune conditions, so things like eosinophilic esophagitis, and obviously GORD as well. The main thing with investigating these kind of patients, you want to send them for a 2-week wait urgent OGD with a biopsy. You can also send the 2-week clinical referral to sort of gastroenterology or surgery, whichever one you want to do, but you must also send a concurrent urgent referral for an OGD procedure. You also do endoscopic ultrasound for locoregional staging, which is not the same as an ERCP, and ERCP is for the biliary tree. You also do a CT tap to rule out any METs, and also for staging. And then sometimes you have to do an FDG PET scan for occult METs, and occasionally sometimes for peritoneal metastatic disease, you have to do a laparoscopic procedure. So that's the only way to really figure out what's going on. Okay, the mainstay of surgery, especially for things that are caught earlier, and they're at T1 M0, is esophagectomy, which is where they cut the tumor out and they connect. So, for example, say you've got a tumor down here, you want to cut that out and join the top bits of the esophagus to the stomach. So you stitch it down there. The main thing with that is going to be, the main complication is like a leak, an anastomotic leak. Okay. Other options for surgery is endoscopic mucosal resection, that's really only for early stage disease, and then you can also do adjuvant chemotherapy, obviously, to make sure that you've killed off all the cancer cells. Next slide, please. So these are some of the barium swallows. The reason I put this in is that if they give you an investigation and examination, sometimes it does help to know what the different barium swallows look like. I'll just go through the big ones. So you'll get, obviously, the copy of these slides once it's uploaded onto Medall. The main thing, if you can zoom into these pictures at your leisure, you'll notice that you've got this stricturing on the esophageal cancer one. But along the length of it, you've still got other tissues that you can see, as opposed to the achalasia, where you've got this corkscrew like tapering, and then it kind of just disappears, right? So what's happening there is at the wall of the esophagus, you've got tumour, it's growing in, it's sort of ingressing in, and then you've got compressive features happening there. And that's why you'll get some of the regurgitation type sensation, the swallowing issues, but that's what it looks like usually on a barium swallow. With achalasia, you can get this bird beak. The other image on the right-hand side of that middle two images is something called corkscrewing. So that when you get esophageal spasm, it'll sort of like twist as well. So you get that corkscrewing. With achalasia, a really important risk factor and quite a life-threatening one is risk of aspiration pneumonia. So if you're worried about that, what that means is you make that patient nil by mouth. So you put a big sign behind their head, behind their bed, and you say nil by mouth, and you put an NG tube in directly into the stomach to bypass all of those issues, essentially. And then the third image is a barium fluoroscopy. So that's a dynamic image. Again, you'll have to zoom in. So there's this funny little sticky out thing that you can see pointing towards the spine, and that's pointing towards a pharyngeal pouch. So people like that, people who have that will have complain of bad breath primarily. They'll also have swallowing issues, obviously, like food gets stuck, or like feeling of like a hair in their throat. They might even get a neck swelling, especially if it's chronic. And again, there's a risk of aspiration pneumonia, because you can imagine it goes up and then tries to go down over the open airway. Okay. It should usually coincide with like C5, C6 on the spine. So that's another way to pick it up. Okay. Next slide, please. So next question. Again, you'll have a minute or so. So you've got a 40-year-old factory worker with plantar fasciitis who's come to ED after a vasovagal episode, who reports a burning sensation in the chest over the last few months, but also adds that he's passed some quite foul-smelling and thick, tarry stools in the last week. Other than taking some over-the-counter pain relief medication for the plantar fasciitis every day for the last 3 months, he's quite well in himself. He's quite pale at the minute. He's got a thready pulse, but his abdomen is soft and non-tender. But there's a lot of epigastric pain sort of just underneath the sternum. Okay, so what's the first line treatment recommended in this patient's management? I have to say, I think at some point all of those answers are right, but what's the first line treatment that's recommended? Treatment being the key word. And the answer is something that doesn't sound like a treatment, sadly, but it is a treatment, because you can do things during that treat the thing that's happening, if that makes sense. I think that's a really good guess. I would probably have gone with like, I think my top picks, if I hadn't obviously written the question, would have been A, D, or E. So I don't blame you for picking E. It's not the answer, unfortunately. So the first line treatment is an emergency OGD. So if we go to the next slide, thank you. So I've just highlighted all the key things. Before I go to the next slide, is it Paul? I think he was messaging. Can you tell me what you think is a diagnosis first of all? No, Paul's gone shy. That's fine. So the answer is an emergency OGD. Although first of all, you'd probably want to do an AT assessment. You want to stabilize the patients. You're going to give them IV fluids and you're going to give them omeprazole. But the first line treatment is an OGD. If you can't, right? He's messaged. He's written something. What has he written? Yes, you're right. So you're unclear, but its tarry stool suggests a bleed. Yes, it does. So what I think is happening here is that this man's got an MSK problem, is plantar fasciitis. Equally, if I swap that out with lower back pain, he would also take pain relief, right? The reason I've put over-the-counter pain relief as opposed to the actual medication he took is because that it would make it too easy then. So essentially, this gentleman is probably taking ibuprofen, being an NSAID. If you take an NSAID every day for that long, you are going to mess up with your kidneys, 1. 2, you are probably going to give yourself gastric ulcers. One of them, those ulcers can either perforate or it can bleed. Strangely, with a perforation, you don't get hemodynamic instability, but with a bleed, you probably will. So he's had a vasovagal episode. That means he's quite likely hypotensive. He's got a thready pulse, and he's pale. So he's not a well man. So he's got bleeding, like you said, from the thick tarry stools. But it's important to note in the history, why has he got thick? Why has he got melena, basically? Why is he bleeding? And you've got exam technique, obviously, and you pick out things like MSK, NSAIDs, but it's really important for clinical practice that people, you ask exactly what they took, because a lot of patients will just say, oh, I can't remember, I've been taking painkillers, I can't remember the name of it, or someone gave me this, that, and the other. But it's really important, because if you don't ask, you will not tell them to stop it. And whilst, yes, you're going to do an emergency OGD, it's equally, well, it's also important that you've started them on IV omeprazole to counteract that. Next slide, please. So saying the question asked for treatment and not first line management. If the question was asked for management, you'd want to do AT, IV fluids, PPI, etc. You do the angiography if the OGD embolization doesn't work. So the reason you do an emergency OGD in the first place, and you would call up the on-call gastroenterology consultant for this, you wouldn't just sort of ask a reg. It's like a overnight thing, bleeding, peptic ulcer, need to get it done, is because they can go south really quickly. Next slide, please. So these are just some of the differentials for heartburn that you can have. So perforated peptic ulcer, so you'll get the GI contents going into the peritoneal cavity. They'll be peritonitic. So I think this gentleman had epigastric pain, but his abdomen was soft, non-tender. If you had a perforated peptic ulcer, they would not be soft, non-tender. It would be painful. So you'd get severe pain and palpitation. You get a tense abdomen. So peritonitic means diffuse abdominal pain, distension, rigidity, possibly guarding. You can get heartburn with acute gastritis, so you get burning in the upper abdominal area. Don't tend to get any melena or any syncope because they're not bleeding out, essentially. You can get bleeding esophageal varices. So in these patients, in their history, they'll have a history usually of like alcohol excess and portal hypertension and cirrhosis, and they might even have vomited blood. In patients with cirrhosis, it's also important to not just always associate things with alcohol excess. You can have other causes of hepatitis, so you need to ask them travel history, but also, well, not travel history, more sort of if they've got hepatitis B, C, anything that's not been treated in the past. The other thing is obviously peptic ulcer. 75% of people with peptic ulcer, you have bleeding as an important complication, and it usually comes from the gastroduodenal artery. Next slide, please. So that was on heartburn differentials. The next one is another theme entirely. So question 8, 45-year-old female with known coloring up to and into the ascending colon presents to the GP with 5 bloody motions per day and mildly pyrexic at 37.6. Some would argue that's not pyrexic, but in this case, she is. It's relative to what her baseline is. She's already on rectal mesalazine. She hasn't had any flare-ups in the last 3 years. What further management can be added to this lady's regimen to help with her symptoms? So this question essentially is testing your recall of algorithm for certain inflammatory conditions, shall I say. You've got 50% chance of picking the right diagnosis in that case. And then go down the treatment algorithm if you can remember. So Paul, you've said A, oral azathioprine. Can you explain to me why? Because you're right, it does play a role in the management of this condition, but I just want to know. It's indicate, yeah, you're right. It's indicate for inflammatory conditions. Yeah, quite right. Okay. Keep a hold of that idea. You're almost right. Okay. If we go to the next slide, please. So it's an oral aminosalicylate. This question also relies on you understanding that mesalazine is an aminosalicylate, and you can get rectal mesalazine and you can get oral mesalazine. So pretty much all of these medications are indicated in IBD. So you've got Crohn's, you've got ulcerative colitis. This lady has ulcerative colitis. So the answer is oral aminosalicylate, because in Crohn's, depending on the severity of the flare-up, it decides what path you go down. So it's a bit more explanatory on the next page if we go to the next slide. So I'm sure there's versions of this on the internet. I've consolidated this from NICE, so you're not going to get this lovely colour scheme, obviously, but you can have this to help you. It always helps me to colour code it. So first you have to grade the ulcerative colitis. Then you've got to figure out whether you're going to induce remission or you're going to maintain remission. So you need to figure out if they've been in remission before. So this lady's having a flare up because you know that she's been in remission for 3 years at least, okay? And she would come under, I think, moderate flare up because she's had 5 stools a day, okay? So if you've got moderate, and you've got to then figure out what type of colitis. She got proctitis, she got a left-sided ulcerative colitis and proctosigmoiditis, or she's got extensive disease. And I think this lady has the middle one. So she's got, because that's why in the question, I don't know if you took a screenshot of it or not, we put, known colitis extending up to and into the ascending colon. So that means that she classifies in the middle one. So you want to add a topical, basically, okay, and then try it and then if it doesn't work, then add the oral steroid, and sometimes you can add a topical steroid as well. Okay. I won't go through the rest of that because otherwise I'm just reading from it, but you've got to essentially memorize it. And what you're doing is you're going down the intervention, you're going sort of up the intervention ladder, and it tends to usually go topical, oral, mesalazine, and then you add the steroids. At some point, if you've got signs of like sepsis or infection, you need to add antibiotics, obviously. And then with the azathioprine, the only place I think the role of it is in ulcerative colitis is if you've got a severe relapse in severe colitis after being in remission for about 2 years, then you need to add things like azathioprine. The other thing to note is that if someone tries to suggest methotrexate for ulcerative colitis, you say no, it's for Crohn's. And anecdotally, I think probiotics are useful for ulcerative colitis, and it's just, I think, to maintain the flora of the gut at a healthy level. Next slide, please. So question 9. I think this is quite a hard question, but if you can get it right, you're flying basically. So question 9 is a 35-year-old female referred from a GP to hospital due to 1 month history of fluctuating diarrhea and constipation, feelings of tenesmus, abdominal cramping. She notes blood on wiping after passing stool, and it's also mixed in her stool. She's a lawyer. She feels work has contributed to her feeling really tired of late, and it's because she's been staying late at work. Her bloods show anemia, microcytic anemia. She's very anxious because she's got a bit of a family history of cancers. Grandma died of endometrial cancer on her father's side, and uncle on her father's side died of colorectal cancer. Both were diagnosed by 50. What gene is likely to be implicated for this lady? The fact that she's a lawyer is not just about the fact, not just to scare you into getting the question right and treating her properly. E. Someone said E. Do you know what? If I didn't know the answer, I would also have said E. I think there's only one thing. That points against it, or rather the absence. In which case this question could probably have been written better. Yeah, you're quite right, Paul. Yeah, I think this question could probably have been written a bit clearer to differentiate between the answer that you're giving and the answer that I thought of. If I said to you, Paul, that there's no polyps on scoping or scans, what would your answer be then? All right, we'll move. Oh, I don't know. No problem. Right, we'll go to the next slide then. So the answer is MLH1, because this lady has got Lynch syndrome. We shouldn't be using Lynch syndrome as a word anymore. So next slide, because of the historical and political reasons. But she's got hereditary non-polyposis colorectal cancer. So with FAP, as was mentioned earlier, you're right, it's got familial link to it, but equally they'll have a large number of polyps in the colon. But this lady's got Lynch syndrome, so it's autosomal dominant. The gene implicated is the MLH1 gene. The other key information in this question is also the fact that it's family history of endometrial and colorectal. So I think that's quite an important. So
if you focus on that, perhaps you might have been able to connect that it's the non-polypoid version of a colorectal cancer, and that might have helped you go down towards HNPCC. I have seen one patient in my life, in my short career, of Lynch syndrome, and they presented with a history of the endometrial and the ovarian cancers in their family. Well, endometrial and colorectal cancer in their family, but they also presented with really strange skin lesions on their chin, which were being treated as sebaceous sort of cysts, but turned out to have turned out when we biopsied, because they didn't respond to antibiotics, turned out to be cancer. So you have to pretty much screen them for every type of cancer. These patients go on to have annual skin surveillance. They tend to be known very well to all the cancer services because they're on a degree of surveillance on every front. They have a lot of genetic counselling for family and also family planning. And as mentioned, that's like, hopefully you did, you picked up on the bowel habit changed, the anemia, the fatigue. And often it's quite difficult, especially if they have jobs that make them tired. You have to try not to underestimate their fatigue and just attribute it to their job. It can be physiological as well, so it's really important to take a clinical history. And the other colorectal oncogenes that you need to be aware of is KRAS and EGFR as well. Okay. Next slide, please. It's the last question, hopefully. Oh, yeah, no, a bit more on colorectal. So, right, sorry. So the next bit is just red flags on 2-week weight. So anyone over the age of 65 with anemia, you have to refer them anyway. Everyone gets a fecal test, immunohistory test, and the main thing to look out for is abdominal masses, bowel habit change. There's different criteria for age groups. So if they're over 40 and they've got unexplained weight loss and abdominal pain, if they're less than 50 and they've got rectal bleeding with unexplained weight loss, and again, abdominal pain. If they're over 50 and they've got rectal bleeding, weight loss, and pain again. If the fit is more than 10, you need to send them for a 2-week urgent colonoscopy. And you offer the fit even if the previous fit's been negative. If you are suspecting on examination or reported rectal mass, you don't need a fit test. You just send them for a 2-week wait regardless. Okay, next slide. Right, so the final question. It's a 60-year-old lady with a known GI disease, presents to ED with fever, feeling more tired, left-sided abdominal pain. She reports passing urine that had a fecal odour, and that it feels like a bubbling sensation when she passes urine. She had a history of going to the GP with vaginal discomfort and infections in the last 12 months. In the last 2 days, she's been feeling worse. Her observations show her to be very pyrexic, very tachycardic, tachypneic, slight drop in her SATs, blood pressure a little bit hypertensive, but not massive. She's tender in the abdomen, she's peritonitic, there's guarding, there's pain in the left-hand side, in the left iliac fossa, and she's got air underneath her diaphragm. What's the most appropriate initial management? And again, as is the theme with most sort of MLA and question banks, they're pretty much all correct at some point. But you've got to pick the most appropriate initial management. I think this is a question that if you get in the MLA, this would be like a red flag question, i.e., like if you get it wrong, you need to get it right. Basically, it's a safety question. B, very good. Yes, it is B. Next slide, please. So I've highlighted the big red flag, red things. Obviously, a lot of the things in this picture mean you need to deal with it urgently, but the things in red make you feel like we need to do something now. So she needs to be treated as a Cat 1 emergency, because this is something that can go south very, very quickly. I'll go to the next slide, please. We'll just talk through it. So, as I said, she might need a CT scan and she'll more than likely need an urgent laparoscopy. But the main thing is we need to stabilise her. First, initial management means to give her antibiotics for her fever, need to give her fluids for her tachycardia and a low BP as part of resus. She's got air under her diaphragm, air in her urine. She's peritonitic, so she needs surgery just on air in the diaphragm and peritonitic, even if you don't understand the significance of air in the urine. So you keep her nil by mouth surgery until further notice. So this lady, based on her history, she's got a background of diverticulitis, and hopefully you picked that up. With the vague and very specific descriptor of known GI disease. The other thing to note is that this lady has been having vaginal discomfort for the last 12 months. So it's a strange thing to not have had it before the 12 months and then suddenly get it in the last 12 months. This business of bubbling sensation in urine means that there's a fistula of some regard. And air and GI material is basically it's exchanging from these two spaces. The surgery of choice for this lady will be a Hartmann's procedure. Oh, right, that's why. We got the answer right because someone's experienced this in the placement, so that's good. This is why placement's really important, so that you can link together your questions and your revision with your exams and training. Next slide, please. That was the last question. Hopefully, I don't think that last one needed much explanation. So these are some of the topics that we've covered from the MLA checklist. Obviously, there's a lot more that we need to go through. We're not going to be able to go through in 2 lectures. So, as I'm sure we've mentioned before, that you have to obviously consolidate your revision with our slides, our questions. The more you do, the better you are at it. But I think we've gone through some of the big the big topics and given you a bit of a challenge in thinking laterally about some of the contents that you can be tested on, isn't it? And I think one of the key bits of advice that I've learned from certainly preparing these notes and also revising for the MLA last year is it's as important to know the diagnosis for the question as it is to know what it isn't. If you get my drift, you need to know what it is and you need to know what it isn't. And in shorthand, I'm saying you got to know everything, which is easier said than done, obviously, and it is hard, but it's usually with practice, pattern recognition. But we really appreciate the engagement, and I think that's the mainstay. You engage with it, you get more out of it. I'm so sorry, Paul. You're the man of the hour, basically, getting all my questions and all of Dr. Sophia's questions. But if you can fill out our feedback, that would be great. And thanks everyone else for coming. If you scan the QR code, it'll take you to our organisation's page, and you can take part in our research. You can give us feedback, obviously, on our sessions. You can claim your certificates that you should be getting from Medal anyway. We've got next week's session on endocrine. I'll be doing that one as well. That one's a really important one to just read up on if you are going to come. Need to know all of your endocrine axes. You'll get more out of the session if you just have a revision of it. And yeah, thanks for engaging. Hopefully that was all right. Any questions? No?
Thanks for coming, everyone. That was brilliant.
Thank you. Thanks, Paul. If we could give you a special certificate, we would.
I'm going to end the session here, but yeah, really appreciate you coming. And if you could fill in the feedback, we'd really, really appreciate that as well.
And we'll see you all next week.
Bye.
Bye.